to move on, and it's a pleasure now to welcome Jonathan Sandoe, who's a consultant microbiologist at Leeds, who has a very interesting, I don't think he's going to talk about it, but interesting registry linking endocarditis with dental procedures, which I think will be important for the future. But we've asked him today to talk about advanced microbiology. Thank you. Thank you.
Thank you very much. Thank you for the invitation to talk. Apologies for changing the order around. There's nothing like an IT glitch to get the adrenaline going. So that's what I'm going to talk about today. Causes of endocarditis, a little bit about blood cultures, hopefully the higher level end of blood culture theory. Some susceptibility testing, background, stroke revision, a little bit about resistance, and a little bit about examination of resected heart valves. This is just to reiterate that we're talking about endocardial infection, native structures, prosthetic valves, pacemakers, all things that have been reiterated today. And my cartoon there, I'd be interested to hear what Kim thinks about this. Not all vegetations are pedunculated oscillating masses. Some of them are adherent, non-oscillating, and therefore quite difficult to pick up on echocardiography, and that can confound the diagnostic dilemmas that we've been talking about. In terms of pathogenesis, a quick revision. Most endocarditis results from, we believe, from a transient bacteremia. Bacteria get into the bloodstream from a number of different sources. Often we have no idea what they are. Alternatively, the bacteria are introduced at the time of cardiac surgery or implantation of a device. That device might be contaminated, so the bug, instead of being in the bloodstream, it perhaps drops from a contaminated skin squame in the operating theatre onto the surface, which it then adheres to, multiplies, secretes all sorts of goo and substances that protect it from host immune system, and at this point there's probably no symptoms in the patient. So that's why I've called this the incubation period. All this is going on and the patient often has no idea that this is happening. At some point, bacteria start being released from the biofilm. That's what causes the inflammatory response. That's what causes the secondary foci of infection. Sometimes much bigger lumps of biofilm, including fibrin and other junk, break off and go down big vessels, which may be the presentation. And alternatively, infection can munch its way through your native valve structures, causing perforations and the valve damage. But it's at this point that we see symptoms, and it's the release of bacteria into the bloodstream that we're trying to detect when we're using our diagnostic tests on blood samples. So in terms of the current causes of infective endocarditis, I really want to reiterate that the causes vary with the type of endocarditis. The pathogens, as John's already said, for early versus late prosthetic valve endocarditis and device-related endocarditis are different from native infections. Staphylococci, I think, now are unequivocally the most important pathogens, well, the most numerous pathogens rather than the most important. Gram-negatives and fungi are actually very, very uncommon. So I reiterate what John said about probably not covering these pathogens empirically in most situations. In terms of blood cultures, the sensitivity and specificity of this test are entirely user dependent. That's one of my key points. The timing of sampling is very important. The skin sampling site is largely unimportant, and there are some alternatives coming, I think. So a brief revision of the sampling strategy with blood cultures. So this black line represents bacteria in the bloodstream coming and going. And a transient bacteremia is bacteria appearing in the bloodstream and disappearing, and that happens to all of us on a fairly regular basis, but can also be precipitated by things like having a urinary catheter changed. Some infections, like pneumonia and pyelonephritis, in the context of urosepsis, you might get a bacteremia, you might get another bacteremia. But the key thing about endocarditis and other endocardial infections is that the bacteremia is fairly constant, which means that whenever you sample the blood, in theory, you should get a positive blood culture. And it's spacing out the blood cultures in time that's important, because it's that demonstrates the persistence of the bacteremia. So if you're trying to separate a transient bacteremia from a persistent bacteremia, you need to know how long a transient bacteremia lasts. You might pick up the tail end of a transient bacteremia, and your subsequent blood cultures you want to be negative before you can be confident of that diagnosis. And the answer to that is, because I've missed out a slide, it's about an hour. So if you sample someone having a urinary catheter change, or a transurethral resection of the prostate, or some invasive procedure that we know causes a bacteremia, there's a peak 10 minutes, 20 minutes after the procedure, and then there's a tail, and within an hour, most patients are no longer bacteremic. There are still occasional patients that are, but it's a relatively transient process, and if you sample, therefore, 6 hours between your blood cultures, then you can be fairly confident that you're not picking up a transient bacteremia if it's positive. Quick illustrative case. A 15-year-old female with congenital heart disease came in with classical symptoms suggestive of endocarditis. She had 3 blood cultures taken, empirical antibiotics were started, and the blood cultures were negative. She didn't respond very well to treatment, continued to be febrile. We reviewed the case, reviewed the blood cultures, and all of the blood cultures, it turns out, were paediatric blood cultures, because she was 15-year-old, so why wouldn't they be? And paediatric blood cultures, they probably put about 1 ml of blood in paediatric blood cultures. So here, this was a situation where antibiotics were stopped, and I agree with John that it's a difficult decision sometimes whether to stop antibiotics and reculture. And I think that patients do become bacteremic sometimes within a shorter period than a month. But the repeat blood cultures in this patient were all positive, and she was able to be put on directed therapy and clinically then improved. So the key thing here was that insufficient blood volume was used. And I think that can happen during clinical practice when people are rushing, they're trying to do a multitude of other blood tests. You have to have the appropriate volume. In endocarditis, the number of bacteria in the bloodstream circulating are often very small. They're often less than 100 per ml of blood. And if you don't put enough blood into the bottles, you're never going to get a positive result. So this would be a pseudo-culture negative endocarditis. It's not because of any quirks of the pathogen. It's about using the test properly. Oh, there's the slide that I was going to show you. Right. Apologies. So this is from Lockhart's trial of prophylaxis for tooth extraction. And they collected blood samples after toothbrushing, after dental extraction with amoxicillin, and after extraction with placebo. But in all cases, you've almost got rid of all the bacteremias after an hour, as I was saying. You'll note that they haven't all gone, hence the recommendations to have sort of 6 hours to ensure that you've really got rid of any transient bacteremia. So the current recommendations are the 3 blood cultures, but I think the key point beyond just take 3 blood cultures is take 3 blood cultures and make sure that there's at least 6 hours between them to confirm that you've got this persistent bacteremia. Now that may not always be practically possible. In the setting of severe sepsis and septic shock, you don't really want to hang around waiting to give that patient antibiotics. Here you're not giving antibiotics because they'll mess up the blood cultures. So while the patient's being resuscitated and assessed, we recommend taking 2 sets of blood cultures within that first hour, then give your empirical treatment as John has already advised. Now, the site, people often say, well, I took it from here, and I took it from here, and then I took it from there, and I took it from somewhere else, and I really don't care, because the key thing is you've got to clean the skin properly. If you can avoid the groins, because there's such a huge amount of bacteria in the groins, then that's good, because that reduces the risk of contamination. But it's much more about the timing and appropriate technique and appropriate skin preparation to reduce the risk of contamination. If you actually swab both antecubital fossae, you'll grow the same species of coagulase negative staphylococci on both sides. We are quite sort of symmetrical in terms of our normal flora. So a new development, mouldy tough mass spec, is coming into a lot of microbiology laboratories. A little technical drawing for you. In practical terms, what the lab does in this technique is take a plate where some bacteria are growing, which looks a bit like this. They can lift a few colonies of this and spread it on one of these circles, so it's quite easy to do. And then they fire a laser at it, and that desorbs and ionizes proteins on in that bacteria, which are then accelerated in the mass spectrometer, and protein particles are separated by their relative mass, and the profiles are then interpreted by a huge database that tells you the identity of the organism. So matrix-assisted laser desorption, ionisation, time of flight mass spectroscopy, which is we call MOLDI, has now enabled us to identify bacteria much more quickly. There's also the possibility of doing this from a blood culture bottle. So when the blood culture flags positive, some labs now, not ours at the moment, I'm sad to say, can take some of the fluid from the blood culture bottle, put it in this system, and you know the organism identity very, very quickly. So all the time, subtle changes in processing mean that the time to giving results is being condensed. But certainly once you get to the point of growth, you haven't got to wait another 24 hours now to know what the name of the bug is, because we can tell you it using this process very quickly. There are some new rapid diagnostic tests under development, like Cycloseptifast, Septitest, Iridica. In Leeds we've got experience of testing this methodology out and have done a big evaluation of this technology. They're all PCR-based processes. I'll talk a little bit more about the science in the next few slides. The long and the short of it is, NICE did a diagnostic assessment of these and said that they couldn't really recommend them yet. And I have to say that they show promise, but they're not as good as blood cultures yet. And I think they will be refined, they will be much better. This, for example, this test could detect down to 200 bacteria per mil of blood with a reasonable degree of accuracy. But quite often in endocarditis you might have 10 or maybe 50 bacteria per mil of blood, so they're not quite sensitive enough. Watch this space. Susceptibility testing and resistance. Key points here: susceptibility testing is necessary to optimise therapy. That may be stating the obvious, but it's pretty important in endocarditis because there's lots of resistance in these bugs that are causing the infection. Isolate identity can partially inform treatment, so John's already made that point, that as a microbiologist we can have a pretty good stab at what is likely to be effective, but we can't 100% know, and I'd much rather have the results if I can. Antimicrobial resistance, I hate to bang on about it, but it's not something that is about future generations, it's right here, right now, and I'm going to tell you about that some more. Some revision of sensitivity testing, in case you didn't know. Most labs take an agar plate and they spread the test bacteria on it with a swab from some kind of liquid medium. They then have these little filter paper discs which are impregnated with antibiotics. They then incubate it for a period of time, which is why there's a delay getting the results. That's usually about 18 hours. And then after the organism has grown, which is this orange stuff, you'll see sometimes a zone of inhibition around an antibiotic. Zone of inhibition. And that tells you whether these antibiotics might be sensitive or resistant. Clearly these ones are resistant and these ones are probably sensitive. And that's what it looks like in real life. So most labs do this as the baseline way of testing. Some will do or have automated systems that will give you very similar results. But this is the most common. If you want to know the minimum inhibitory concentration, which is a more sophisticated way of measuring susceptibility and gives you a number, instead of just sensitive or resistant, we can actually tell you a number, then most labs now use this system. The same idea, you spread bacteria on a plate, but this time instead of a filter paper disc, you've got a strip with a gradation on it, and antibiotics are impregnated in this strip. They diffuse into the media and cause inhibition in an ellipse, and where the ellipse crosses this strip tells you the MIC. So a brilliant invention, because it means that labs didn't have to have piles and piles of test tubes and labour-intensive MIC testing equipment. I'm not sure whether it's still the best test or not, but that's what's done. Usually we test Pseudomonas aeruginosa in our lab to aztreonam, ciprofloxacin, piperacillin, tazobactam, meropenem, sometimes gentamicin. I don't know if that alarms you, but it certainly alarmed me. So this is a multi-resistant organism. I don't know how many people in the room have used colistin ever to treat a patient with endocarditis, or fosfomycin. They're not things that we're currently using. So I've got consent from this patient to present the details because he's potentially identifiable and is a current inpatient. And actually I would value some feedback and discussion around this case anyway, and he knows that I'm going to present it. Right, how am I doing for time? Resected heart, am I right for time? Key message here is that 16S ribosomal gene PCR influences patient care. So it's not just a nicety that we microbiologists like to do. So normally you do a microscopy on resected heart valve tissue, and if you're lucky, histology. Then it's cultured, and more often than not, it's culture negative. So we do this thing called broad-range PCR. Broad-range PCR works because Kim's already shown you when you chop up a heart valve and have a look at it, there's a massive amount of bacteria and hence a huge amount of target nucleic acid in those cells. And that's why you can do these kind of diagnostic tests on heart valve tissue, because you've got lots and lots of target and it outweighs all of the contamination that's around us. So brief bit of explanation for this. All bacteria have ribosomes because they need to make protein, so it's a fairly fundamental bit of kit. In this fancy cartoon here that I've pinched from the internet, the orange and red bit is the active site of the ribosome. That's where all the action happens. If you get mutations in that area, then it ceases to, or significant mutations, then the ribosome ceases to function and that cell line will die out. So what that means is that the nucleotide sequences encoding for that part of the ribosome are highly conserved among all bacteria. And if you unfold the gene that codes for the ribosome, you have bits which are highly conserved amongst all bacteria. In between those bits, around the outside, the grey and the pink and the blue on this drawing, that can mutate away to the bacteria's heart's content, so to speak, without it affecting function. So in between the conserved regions are highly variable regions. And this broad-range PCR works by having PCR primers that attach to the highly conserved areas and they amplify across the highly variable regions. And the process then is to amplify that target by PCR. You then end up with species-specific variable regions in that PCR product, and you do a complete sequence determination on all of these results, and then you compare that sequence data with database sequences which look a bit like this, and they tell you the bacterial species. So it's a fantastic bit of technology. And this is also the technology being used in a lot of those new diagnostic tests, because there are lots of different primers that people have designed, and they will, to a certain extent, amplify more gram-negatives or more gram-positives, and they're all some form of multiplex PCR with lots of these reactions going on in clever kits. Does it make any difference? So this shows you how many, up to 2011, so not massively up to date, but the graph carries on very similar to this. So we tested about 15 per year, because not all heart valves have this done to them. If they grow a bacterium, there's no point in doing this technology. So it's very selective. Heart valve tissues that are culture negative, we carry this test out. And there's a high degree of positivity, so that's a pretty good result. 5 to 10% of all blood cultures that are taken are positive by comparison. And most of the time this has what I've called here added value. So that might mean that the result changes the patient's antibiotic treatments entirely. It might change their treatment partially. It might change the microbiological diagnosis, which results in other diagnostic tests to find out where the infection's gone or where it's come from. So blood cultures are still key in endocarditis. Appropriate sampling is vital, and if you don't do it right, you'll get false negatives and false positives. Number and timing really depends on the clinical presentation and the context. Antibiotic resistance is very important in endocarditis because a lot of the pathogens we treat are resistant. There will be some new technologies coming into clinical use fairly soon, and I would recommend that 16S PCR is routinely carried out on heart valves that are culture negative.
Okay, thank you. Any questions? Oh yes, David.
Thank you, Jonathan. Enjoyed your talk. I just want to make a comment, firstly, about sampling of blood in adults. That would you agree that 20 ml of blood per blood culture set is better than 10 ml? So the 2 bottles, putting 10 ml in each bottle rather than just 5 ml would be best. And the other quick point about the Pseudomonas patient you presented. Was the patient on immunosuppression still? Had a bone marrow transplant previously. Perhaps if there was less immunocompromised state, it might help as well. What do you think?
So, in response to the first comment, thank you for the clarification. Most blood culture manufacturers recommend 8 to 10 mils per bottle, not per set. So if I've misled anyone, then it's absolutely correct. It should be 8 to 10 mils per bottle. Second point is the patient has been on immunosuppression but is no longer, for that very reason.
Thanks, Jonathan. What's your policy on antibiotic use post-operatively in patients who've obviously had their surgery for infective endocarditis?
I did have some slides for that. I took them out because I didn't have enough time. You might want to hear John's view on this as well, because I think he uses even less antibiotic than I do, because of his predecessor being very opposed to antibiotics post-surgery. So my view is to look at the pathogen, how the patient's responded to initial antibiotic treatment, and what the surgeon finds at operation as being key bits of information. If the surgery is confined to the valve leaflets, there's no fistula formation or abscess formation, then surgery is probably curative. And unless there are extracardiac foci of infection that haven't been adequately treated, in theory those patients could probably stop antibiotics very soon after their surgery. In practice, we tend to wait for the results of valve cultures before making that decision, so all patients end up with some antibiotics. The median value in Leeds is between 1 and 2 weeks of post-operative antibiotics. So we don't give very much. So in someone who's got positive cultures and has very extensive infection with fistula formation or abscess formation, they tend to get a standard 6 weeks. So if the new valve has gone into an obviously infected site with culture positivity and poor quality tissues, then I would start that again as almost like a course of treatment for early prosthetic valve endocarditis and give 6 weeks. In most other situations, it's a short course. Okay.
Thank you, Jonathan. I think I have got one question I'd quite like to ask you, if you don't mind. The rise of Staph aureus, which of course you said has a number of causes, but is one of the causes selection bias? Because most of us work in tertiary centres, and all the published series, most of the published series, are also from tertiary centres. So is it just that they're sicker and therefore get to where they're going to research papers, and the less severe, the oral streps stay in district hospitals and don't get counted so often in these series? I mean, so is it partly artefactual, do you think?
I think we don't know because we haven't got good data from.
Well, we don't have good
general
data.
Hospitals.
I guess that's right. Yeah.
So I'm endeavouring to get that data. I think big factors are going to be your intravenous drug use population and your hemodialysis populations in terms of native. So I've shown the native valve endocarditis data, and Staph aureus is still prominent even in our data, and that's influenced by hemodialysis and drug use, I'm sure. So the hemodialysis population is slowly going up over time, and so that's contributing.
Thank you. So, in conclusion, just as a kind of take-home, extracting slightly artificially a take-home message, I think endocarditis is difficult, and there are these rules which get put up by people who write guidelines, but actually every case is individual. I don't know if you agree with that. Almost every case deviates from the guidelines and needs an individual approach. So I think the several speakers have said this, but a team approach, different experts discussing every case, is actually vital to managing endocarditis properly.